Hi, good evening, colleagues. Thank you again for your attendance. And we'll start our meeting with a prayer. So let's place ourselves in the presence of the Lord. Dear Almighty and ever-loving God, we glorify and thank you. You have showered us with so much blessings. Your presence continuously reminds us of your faithfulness and guidance. We humbly ask you to shower our speakers today of your greatest inspiration, so that they may share the most of their knowledge, heart, and soul to their respective topic. May we absorb the invaluable knowledge and put it into practice what we may learn today. We pray that you bless all communities in charge, that they may be able to fulfill their tasks responsibly, that the objectives they have set may all be achieved. Your infinite blessing would mean the success of this activity. May we be living witnesses of your genuine love through the enactment of the knowledge acquired through this activity. We ask this in the name of Jesus Christ, our Lord and Savior, with the intercession of the Blessed Virgin Mary. Amen.
Philippine Society of Diabetologists. PSD's mission: the pursuit of excellence in diabetology. PSD's vision: excellence in diabetology. PSD's objective: to keep abreast of the most recent developments in all fields of diabetes research, education, and treatment.
PSD Statement of Purpose. The purpose of PSD is to give persons with diabetes lives with qualities unaffected by the condition. This is their right more than a privilege. This passion sustains and empowers us to find meaning and fulfillment. The purpose of PSD is to understand and accept that diabetes is a complex condition affecting an individual, the family and community. Knowledge of its biomolecular and cellular origins and understanding all its interventions are as important as mastering its psychosocial dynamics. The purpose of PSD is to be a family of responsible persons bonded by one passion. Agreeing in disagreements strengthen our unity. Criticisms fuel our growth. Love fills our camaraderie. The purpose of PSD is to be a source of inspiration that informs, guides, and corrects one another in daily practice. We find happiness in sharing knowledge and experiences that improve patient lives. The purpose of PSD is support individuals and organizations with similar noble goals, acknowledging that we all live in one world and fighting diabetes together multiplies good outcomes with a fraction of the effort. Collaboration drives inspiration, motivation and creativity. The purpose of PSD is to welcome the cure. When diabetes no longer exists, we will reincarnate with new passion and direction. Our vision will evolve with time, but the family lives on.
So that is our mission, vision, objective, and the purpose. So here is our present PSD Board of Directors, Dr. Elvin Fernando as our president, yours truly as the vice. We have Dr. Jamie Agra as the secretary, Dr. Marcy Cruz, our treasurer, and Dr. Fatma as our auditor. So welcome to our PSD Select session for this evening or for this month. So PSD Select is a special edition lectures. So during this pandemic, we are ngayon lockdown na naman uli dyan sa inyo sa NCR and other parts of the region. So the board of directors have taken this opportunity again to enhance our knowledge in pursuit of diabetes excellence. So this is our third PSD special edition lectures. Okay. Next. So the objective, kung mapansin nyo, yung ating theme for this PSD Select 3 is DM Basics and Complications. So we will discuss the updates in the physiopathology and management of micro and macrovascular complications of diabetes. So last month, we had a very exciting part, which is the complications in the heart, heart failure. For tonight, we are very fortunate to have a pharmacy ME grant from AstraZeneca, and their topic is going to be synergies in the spectrum of kidney disease management in type 2 diabetes. And we have two prominent speakers, Dr. Grace De Los Santos and Dr. Benjamin Balmores. And after that, we'll be discussing about diabetes and kidneys. And the new guideline is diabetes in CKD with our very special guest, Dr. Froilan De Leon. So again, let's thank AstraZeneca for this pharmacy and grant, the makers of your dapagliflozin, Forsigad, dapagliflozin plus metformin, your Sigduo XR, and your combination of dapagliflozin and saxagliptin, your Qter. So to introduce our speakers, our first speaker will be talking about, our first speaker is Dr. Benjamin Balmores. He took his residency in internal medicine and fellowship in nephrology at the St. Luke's Medical Center in Quezon City. He is the past president of the Philippine Society of Nephrology and member of the board of the Philippine Society of Hypertension. Also a member of the American Society of Nephrology, the International Society of Nephrology, European Renal Association, and European Dialysis and Transplant Association, as well as the Transplant Society of the Philippines. Presently, he is a faculty associate professor at the St. Luke's Medical Center, College of Medicine. He is an active consultant at the St. Luke's Medical Center in QC and DGC and the National Kidney and Transplant Institute. Followed him is Dr. Grace De Los Santos. She is the immediate past president of Diabetes Philippines as well as the Philippine Society of Diabetologists. She is the faculty of the Institute for Studies on Diabetes Foundation and the assistant director of our education unit. And lastly, she is the director of medical education and the chief of clinics and an active consultant at the Metropolitan Medical Center. So friends, let's give a warm applause to our two speakers.
Good evening. I'd like to thank the organizer of the Philippine Society of Diabetology for inviting us to be with you and discuss on the topic synergies in the spectrum of kidney disease management in type 2 diabetes. So CKD causes a global burden as it disproportionately affects socially disadvantaged populations. CKD also affects the disability-adjusted life year or the daily of the different countries and continents with varied rates of affectation from a low number represented by the blue color to a high value represented by the red color. Based on the Philippine Renal Disease Registry or the PRDR report in 2017, we can see here that there is an increasing trend in both the prevalence and incidence of CKD in the Philippines. Again, based on the PRDR report in 2017, diabetes remains to be the leading cause of ESRD in the Philippines, followed by hypertension and chronic glomerulonephritis. This is a spectrum or continuum of CKD, starting when you screen patients for CKD risk factors. As we identify certain risk factors, we risk stratify them and aim for risk reduction. And once they are diagnosed to have CKD, treatment follows, including treatment of comorbid conditions to slow down its progression. As GFR declines, we estimate the rate of progression, treat the concomitant complications, and eventually prepare them for kidney replacement therapy. And when they reach ESRD, we initiate them on either dialysis or kidney transplantation. This stage of CKD will eventually affect survival. diabetic kidney disease can be underdiagnosed, undertreated, underrecognized. And it's a fact that the diabetic kidney disease is a silent disease. In October 2019, the International Society of Nephrology, or ISN, set up the KDIGO Controversies Conference in Mexico to discuss the early identification and intervention of CKD. So they just looked at conclusions on the controversies, looking at first the population for CKD screening, risk stratification, and treatment. And they say that all patients with diabetes, hypertension, and cardiovascular disease should be screened and should be implemented in other high-risk individuals and populations based on comorbidities, environmental exposures, or genetic risk factors. The initiation, frequency, or cessation of CKD screening should be individualized. So this is the conceptual framework of CKD screening, risk stratification, and treatment. So it starts with the identification of individual or population level risk, and then followed by screening. It's either you confirm the diagnosis of CKD or no CKD diagnosis at all. If no diagnosis of CKD is made at a particular time, you may do re-screening. If CKD is diagnosed or confirmed, you do the risk stratification for staging and prognostication, and eventually treat them. So screening for CKD starts at looking at potential risk factors for susceptibility to and initiation of CKD. Identify those at risk individuals and populations, such as those with diabetes, hypertension, and or cardiovascular disease, as well as other factors like demographic, older age, and so on. So these are conditions, as what mentioned earlier, conditions of increased CKD risk. And while screening for CKD recommends the use of your urinary albumin-creatinine ratio, or ACR, to detect albuminuria, and the use of your serum creatinine and cystatin C to estimate glomerular filtration rate. So from this, we can see the measurements of early CKD, as what was mentioned earlier, the dual assessment using the eGFR and urinary albumin-creatinine ratio, and estimation of GFR uses creatinine and cystatin C for measurement for initial diagnosis and staging. So this is the criteria for diagnosis of CKD based on markers of kidney damage. You can have one or more of these in terms of albuminuria, urinary sediments, electrolytes, and so on, and diagnosis by GFR. And these parameters should be, or abnormalities should have been present for more than 3 months to qualify for CKD. So these are just the comments that they use why they base their diagnosis on duration, GFR, and kidney damage. Regarding the duration of more than 3 months, this will distinguish chronic from acute kidney disease, and documentation of duration is not declared in epidemiologic studies. Regarding to the GFR value, the GFR remains to be the best overall index of kidney function in both health and diseases. Using your estimated equations, using your creatinine and cystatin C, while kidney damage is represented by your albuminuria as a marker of kidney damage. We have the definition of urine albumin excretion rate of more than 30 milligrams in 24 hours. So the NKF, or the National Kidney Foundation, recommends the use of screening tools for eGFR, such as the CKD-EPI equation to estimate GFR, but there are other calculators that you can use recommended by NKF. So this is just the GFR equation showing that these equations may be helpful in estimating GFR using the same creatinine level as seen in the board, and same creatinine level, same gender, but at different age groups, showing that the equation can estimate different GFR using the above data. So this is just some of the calculators that you can upload or in the App Store. So this is, we can see here the link between the normal or the renal function measured by eGFR and mortality as well as cardiovascular events. And there is an increase, you can see here that there's an increase in the rate of death as GFR declines to CKD stage 5. You know, you can see here that as they progress to CKD stage 5 of CKD, there's an increased rate of mortality. The same with cardiovascular events. As the GFR declines, there's an increasing trend of cardiovascular events. So screening tools for UACR utilizes the urine albumin concentration divided by the urine creatinine concentration. So you divide the two and you get your urine albumin creatinine ratio. And this is a spot determination for quantification of proteinuria. And usually the first void urine is preferable. Now this is just a table of urine assays to determine albuminuria and proteinuria. The spot UACR or urine albumin creatinine ratio is an easier tool to gauge the level of albuminuria and less cumbersome compared with the 24-hour collection or urine 24-hour urine collection for albumin. So you can see the different values corresponding values based on what so these are just some factors that affects urinary albumin creatinine ratio, no? From physiologic transient elevations, intra-individual variability, non-renal causes, and analytical factors. These are just relative risks, summary of relative risks, using a meta-analysis analyzing the link of UACR to different cardiovascular parameters. No? We can see here that the higher UACR, represented by the red line and dots in all the graphs stated there, are associated with higher hazard ratios as GFR declines, such as your all-cause mortality, cardiovascular mortality, rate of progression to ESRD, incidence of acute kidney injury, and odds ratio of progressive CKD. This is the current nomenclature of CKD used by KDIGO, and they utilize the GFR level on the left side and the albuminuria on the right side. The GFR is graded from G1 to G5, from greater or normal to 90 ml per minute to as low as less than 15 ml per minute, which corresponds to G5. And the albuminuria from A1 to A3, A1 from normal of less than 30 milligrams per gram to as high as A3, no? More than 300 milligrams per gram. No? And this is the CKD risk map, and using the table also we saw earlier. No? And those with G1 to G3 and A1 to A2 classification, this one recommends that CKD patients should be monitored closely. You know, from here, from G1 to G3B, A1 to A2 recommends monitoring of renal function. But once they are having A3 level of albuminuria and G4, G5 classification, they need to be referred to a nephrologist. So these are the recommended items for referral to a specialist kidney care services for people with CKD. No? So these are some based on the GFR decline, presence of albuminuria, typical progression of CKD, presence of urinary RBCs, and presence of refractory CKD, hypertension in CKD patient, and so on. So this is just also recommendations based on the interventions for CKD, and this rationale for intervention is intended to delay CKD progression and reduce your cardiovascular risk. And accurate diagnosis and staging of CKD are necessary to utilize treatments effectively. Now, this is a summary of what we have discussed earlier from the time they were screened using your urinary albumin creatinine ratio, cystatin C, and creatinine for estimation of eGFR. And we looked at the criteria used for the diagnosis of CKD until they are risk stratified, and eventually utilize treatments effectively based on the staging. And these are just interventions to slow down CKD progression. And you can see here that they already included the use of your SGLT2 inhibitors and your GLP-1 receptor agonists. So this is just a stepwise guideline by the KDIGO for the management of diabetes and CKD. It was released in September 2020. They recommend the use of lifestyle therapy, and the first line therapy, they recommend the use of metformin and plus your SGLT2 inhibitor. And looking at the cutoff GFR level of 30 ml per minute, which both regimens, but when the level falls below 30 ml per minute, both are discontinued. Additional regimens that they recommend is the use of your GLP-1 receptor agonists, DPP-4 inhibitors, sulfonylurea, insulin, and so on. And they said that the first, this also shows that the use of your SGLT2 inhibitor can be added to other anti-hyperglycemic medications for patients with diabetes whose glycemic targets are not currently met, or who are meeting glycemic targets but can safely attain a lower target. So in summary, all individuals should be assessed as part of routine health encounters to determine whether they are at increased risk of developing CKD. Individuals at increased risk of developing CKD should undergo testing for markers of kidney damage and to estimate the level of GFR. Screening tools such as GFR and UACR for the diagnosis of and monitoring CKD is recommended. Now, there is also the definition and classification of CKD based on the cause, GFR, and albuminuria categories in order to provide appropriate treatment approaches. Individuals found to have CKD should be evaluated and treated according to stage of CKD, and also recognize co-management and referral of patients to nephrology specialists when appropriate in order to improve outcomes in CKD. Thank you.
Good evening, colleagues from ISD, PSD membership. Thank you for attending this webinar. The first lecture was dealing on the importance of the screening and management of patients with CKD. Among our diabetic patients, cardiovascular disease and chronic kidney disease are both very important because they are the most number of complications that we encounter in our practice. Now, it has been discussed that the presence of eGFR, lowering of the eGFR, and also your albuminuria are associated with increased risk of cardiovascular mortality. Now, this slide from the Chronic Kidney Disease Prognosis Consortium showed us that in the presence of high albuminuria, high amount of albuminuria presence in the urine, and also the decreasing eGFR of patients on the left frame, all are associated with increased cardiovascular mortality. And also, some studies have shown also that it is related, both of them are related also to the all-cause mortality of our diabetic patients. And from the discussion earlier with our heat map that was presented, then you can see that the proteinuria is more important, or has carried a worse prognosis than the decreasing eGFR of our renal patient. So in the last few years, in the 2 decades that have passed, we have seen a lot of improvement for the reducing MI, stroke, okay, even amputations among our patients. But you can see from this particular slide that there is not much decrease in the incidence of chronic kidney disease, okay, here in the very light yellow line, in the development or management or medicine being developed to control or delay the onset of your end-stage renal disease. So it has been frustrating for many of our nephrologists that nothing had been developed since after the development of the ARB and the ACE inhibitor showing some benefit on the progression or development of our end-stage kidney disease. So after the EMPA-REG study, which is the cardiovascular outcome trial of empagliflozin, it has been shown that aside from the cardiovascular benefit that was derived from the empagliflozin or the SGLT2 inhibitors, that in the secondary outcome, they noticed that there was a reduction of your progression of your kidney outcome. So from that time on, even the other two SGLT2 inhibitors also showed reduction or benefits on all cardiovascular outcome and also on the renal outcome. So here we have the DECLARE, which has been discussed many times before, investigating the cardiovascular outcome of dapagliflozin. And this is the longest and the trial that involved many individuals. Different from our EMPA-REG study, DECLARE involved patients who are only at high risk for cardiovascular disease. So meaning patients more than 55-year-old male and more than 60-year-old female, plus one or two or at least one of the other risk factors. So aside from being diabetic, so they have at least two risk factors. So aside from being a diabetes, then they have dyslipidemias, hypertension, or a chronic smoker. And or patients more than 40 years old, so younger individuals, diabetic patients, these are all diabetic patients, younger patients more than 40 years old with established atherosclerotic cardiovascular disease. So this is a completely different patient population from the EMPA-REG. EMPA-REG involved only 99.9% of their patients' involvement or patient included in the EMPA-REG studies are all with established cardiovascular disease. So we can see that DECLARE, okay, involved patients who are only at risk. So if it shows any benefit, then it means that it can be used for primary prevention. And for patients who are already have established cardiovascular disease, so this is a medication that we can use for secondary cardiovascular prevention. So the proportion of the participants in this particular is around 60%, as again 40%. So 60% with your 60% without established cardiovascular disease, and 40% with already established cardiovascular disease. So the final outcome of the primary outcome of our study, the DECLARE study, shows that there is significant reduction of the 17% reduction here in the upper frame, showing that there is a 17% reduction in the cardiovascular death or hospitalization for heart failure, but it did not show a significant reduction in the 3-point MACE. Okay, so the 3-point MACE is your cardiovascular death and non-fatal MI and also stroke, okay, non-fatal stroke. But because of this, these are the two primary outcomes that were previously already determined from the DECLARE study. So the secondary outcome of the renal composite endpoint, or the death from any cause, death from any cause, these are the secondary outcome that they want to establish. Now, usually this secondary outcome will become exploratory if one of the or the major outcome does not show a significant benefit, okay, from the medication. So the 3-point MACE did not reach significant superiority because it passes the line of unity. But it's only a little, 1.03. Lumampas lang siya ng konti. So hindi naging significant. So all the other results will become exploratory. Ibig sabihin, pag naging exploratory, we cannot say it is significant. Although it shows here in the renal outcome that there is a 24% reduction and it was significantly reduced. However, because the 3-point MACE was not proven to be significantly showing some benefit, then the renal outcome becomes just a exploratory outcome, and because of this, it is hypothesis generating. And that's the reason why this is another way of showing it in a closer, in a bigger view. The results from heart failure, hospitalization, significantly 27% reduction. And a 47% reduction in the occurrence of renal specific composite. So the secondary outcome was significant, okay, because it did not cross the line of unity. Even on, and this particular study, since I mentioned earlier that the ARB or the ACE inhibitor are the mainstay in the management of patients suffering from renal disease of any cause. So in this particular DECLARE study, they included patients who are already looking at the renal outcome. All the patients with renal problem, okay, had already used the maximum or tolerated dose of your RAS medications. Okay, so for the DECLARE TIMI study, it shows that all of the renal composite outcome was significant here. So the eGFR reduction of more than 40 to less than 60, okay, or renal death or cardiovascular death, eGFR decreasing, okay, and then the individual component also, each separately from the different renal outcomes. And it shows all of them except for the renal death and the cardiovascular death to be crossing the line of unity. However, in the dapagliflozin cardiovascular study, the DECLARE study, it shows that not only it decreased the likelihood of patients deteriorating to worse albuminuria category, showing from normal to macro, so there is deterioration, normal to micro, and normal to micro or macro, or micro to macro, all of them are significantly beneficial or reduced. Okay? Now, how about, does it increase the likelihood of patient improving in the different albuminuria category regardless of the baseline urinary albumin creatinine ratio? So it shows from micro to normal, so that's an improvement, macro to normal, an improvement, and macro to normal or micro to normal, then those are improvement. And we can see that all of them also did not cross the line of unity, and they all favor the medications or people taking the dapagliflozin was favored. So there was not only a decrease in the deterioration, but also there was improved in the albuminuria category. If we look at the renal status of a patient, we usually not just look at the eGFR level in our diabetic patients, but also in the amount of the albumin that are being excreted in the urine. Okay, and even for the eGFR, okay, this panel shows the different level of their renal functions, okay, renal status. So it favors, you can see that after 4 years that you can see that it flattens, okay, the ones taking the dapagliflozin, the curve flatter, okay, it does not goes down, it flattens, and it favors most. It just means that patients with a baseline eGFR with a lower eGFR of less than 60, they benefit more from the dapagliflozin compared to those with a normal eGFR at baseline. So in the DECLARE study, the conclusion from the renal aspect, it shows that there is the reduced risk for the onset and progression of renal dysfunction and kidney disease. It also reduced the risk for renal specific outcome by 47%. And the benefit, okay, is consistent regardless of the baseline EGFR, favoring more for the lower EGFR level, degree of proteinuria, or the ACE or ARB or the RAS inhibitors used. And the progressive decline in the EGFR was attenuated over 4 years of time. So because of that exploratory outcome, okay, exploratory finding in the DECLARE study, so they thought, let's do the use of the effect of dapagliflozin on patients with chronic kidney disease. Because you can see from the DECLARE, they included patients with normal and or your uh, impaired renal function. So they concentrate now with the patients with already chronic kidney disease. Okay, so this is study that CKD is a study involving only patients with chronic kidney disease. Okay, so they included patients with EGFR between 25 and 75 mil per minute per 1.73 meters square with a UCAR or urinary albumin creatinine ratio of up to 5,000. So more than 200 and less than 5,000. It is a rather very high level of urinary albumin excretion. And they are all on maximum tolerated dose of either ACE inhibitors or ARB for at least 4 weeks. Patients who are type 1, patients who have stage 4 heart failure, they are not included. Okay, they are not included, or patients who had MI or stroke, okay, or a TIA less than 8 weeks prior to admission or to enrollment, they are not included. But if their MI had occurred, or stroke or TIA had a stroke occurred more than 8 weeks before the enrollment, they can be accepted. So it's clear that in this particular study, all patients have CKD, but not all has diabetes. They may or may not have diabetes, or they may or may not have CVD or cardiovascular event. Okay, so the recent cardiovascular event recently cannot be included, but those before 8 weeks ago can be included. So we have different population group in this particular study. So the primary endpoint is time to first event of any, so it's event-driven study. Okay, first event of more than 50% sustained decline in your EGFR, even up to 15 mil per minute per meter per mil per minute per 1.73 meters square, even reaching up to the stage of end-stage renal disease, or patients reported cardiovascular death or renal death. And the secondary endpoint is the first event, again, first event of any of the composite of your more than 50%. So they are separated. You can have either one or the other. Okay, so the first event of any of the component of the composite of cardiovascular death or heart failure or death from any cause. It's supposed to be a 45 months study. Okay, and the number of patients that were enrolled was 43, and they were randomized into 10 milligrams of dapagliflozin or placebo, plus of course the standard of care, which is your ACE inhibitor, and if they had already their cardiovascular event in the past, whatever their medications are taking, they can continue on that. If they're diabetic, as long as they are not taking any of the SGLT2 inhibitors, then they are included. So regarding the cost of the inclusion of the inclusion of the participants, okay, because not all of them are diabetic, but 67.5, okay, are diabetic, okay. And when you look at the causes of the kidney disease that the patients is suffering, Okay, again, 58.3% are due to the diabetes. Okay, only about 9.6% is due to your glomerulonephritis. Okay, ischemic and hypertensive nephropathy is about 16, contributed about 16%, and 16.1%, the cause of the renal disease is not known. So let's move down to the diabetes status, okay? Since this is a PSD activity, so we'll just discuss the subgroup of diabetic patients in the DAPA-CKD study. So here at looking at the primary and secondary endpoints in type 2 diabetes with chronic kidney disease, okay, so limited to type 2 diabetes, whether they have previous cardiovascular event or not. So with type 2 diabetic patients, okay, the primary outcome, it shows a 36% reduction. Okay, that is a primary outcome of your composite of your renal outcome, which is your decline, more than 50% decline of your EGFR, even up to the development of your end-stage renal disease or development of renal death or cardiovascular death. Aside from that, the renal specific outcome, okay, you have a 43% reduction. CV death or cardiovascular or heart failure, you have a 30% reduction. And all-cause mortality, again, there is a significant reduction of 26%. So here in the secondary renal specific composite endpoint of the more than 50% decline up to end-stage renal disease or renal death, based on the looking only at the patients with diabetes, it shows a very significant lowering of 43% risk reduction. Now regarding, of course, it's good for our kidney, but is it safe for the other organs, okay? So any adverse event was comparable with the placebo. So there is no increased serious event compared to the placebo-treated group. Now, the ones that are afraid to use the SGLT2, there is the problem of amputation. We always look at that. Development of ketoacidosis, the problem of fracture. All of them did not show increased incidence of this problem in the dapagliflozin treated group. And also from the problem of hypoglycemia, which is one of our barrier of our patients reaching goal, okay, there is not increase compared to the placebo-treated group. Now, another problem that we often are afraid with from the SGLT2 inhibitors use is the volume depletion. But we can all avoid this, okay, if ever it does happen, okay, it will not, you can minimize its happening is by drinking more water. When the patients come to you, looking at the specific gravity of the patients, you will be able to know the status, the hydration status of our patients. So a very high level of your specific gravity in your urine. So pay some attention to the specific gravity number, okay, the level or the result of the specific gravity. If it's high, then encourage our patients to take more water. Now, even when you try to prescribe the medications, ask them to take some water, more water than before, 3 or 4 glasses more water than before they were prescribed the SGLT2. Regarding the amputations, try to be cautious or not to prescribe this for somebody with already peripheral artery disease. Okay, so yung mga sumasakit na yung paa habang lumalakad, may Raynaud's phenomenon, okay, try to avoid it. Okay, and then the ketoacidosis, in cases of when patients are in a serious critical condition, try to stop, or if the patient is undergoing the operations or any kind of surgery, stop it 2 days before, and you can restart it 2 days after, just like what we are dealing with our metformin therapy. Okay. And about the other like genital infections, okay, which are often been related or attributed to the use of your SGLT2. In this particular study, we see some, okay, but personally, I have used a lot of the SGLT2, including your Forxiga, that I had not encountered any except for one. Okay, she was taking another. She was taking another. So when we try to prescribe the SGLT2, we have to advise them to do good hygiene, personal hygiene. Okay, so because of the study, the DAPA, the DAPA study, dapagliflozin study. Okay, you're declared your DAPA CKD and DAPA heart failure. It is currently indicated for treatment of diabetes as an adjunct. Of course, diet and exercise is very important. We cannot do away with it. And the prevention of new or worsening heart failure from the DAPA heart failure study, or cardiovascular death and nephropathy in adults with your type 2 diabetes, and also indicated for treatment of heart failure in adult patients with reduced ejection fraction. So the renal study and the heart failure study, they involve patients who are not diabetic, because the dapagliflozin and all the other SGLT2, they are not supposed to cause hypoglycemia if used alone, But it can cause hypoglycemia when used together with your sulfonylureas or your insulin. So personally, I will always put my SGLT2 in the morning, and then if they have to be concurrently prescribed with sulfonylurea, I usually will place them in the before lunchtime or before their biggest meal of the day, which is not supposed to be, but the patients usually will have one bigger meal than the other. Okay, so I'll prescribe it that way, because if you put them all together in the morning, then the patients may have some hypoglycemic episodes before lunchtime. So I think this is my last slide. Thank you for your attention.
Thank you very much, Dr. Grace de los Santos and Dr. Balmores. And to our friends from AstraZeneca, represented by Sir Kem Reyes and Sir Malvin Magdangal and Sir Noel Macoy. So thank you very much for your generosity. And to introduce our next speaker, inside, sir, please. Okay, so it's an honor for me to introduce our prominent and much sought nephrologist and speaker in our country. So he is an associate professor at the UST Faculty of Medicine and Surgery, the past section chief of nephrology at San Juan de Dios Hospital, also the past section chief of nephrology at UST, Faculty of Medicine and Surgery, UST Hospital. Our speaker has received many awards, including Special Award for Community Service by the Philippine Society of Nephrology, Special Award for Medical Education by the Philippine Society of Nephrology, and the Distinguished Fellow of the Philippine College of Physicians. Friends, let's all give a warm applause to our Dr. Froilan De Leon to talk about KDIGO 2020 Clinical Practice Guideline in Diabetes Management in CKD. Good evening, sir.
Practice guidelines tasked to talk about the kidney disease, improving global outcomes, 2020 clinical practice guidelines on diabetes management in chronic kidney disease or CKD. These are my disclosures. And let's start with definition of terms. When we talk about chronic kidney disease or CKD, it is the condition where there are abnormalities of kidney structure or function which has been present for more than 3 months. And it is classified as to cause, GFR or glomerular filtration rate, and urine albumin excretion, abbreviated as CGA. You're quite familiar with this map. This is what we call the heat map, and this is a risk stratification produced by KDCO. Okay, so as your GFR decreases and your urine albumin excretion increases, the prognosis of CKD becomes poorer. And it is very important that I want to emphasize this, that you must include urine albumin excretion in your screening and in your diagnosis of patients with chronic kidney disease. And let me show this. Let me show this by giving you an example. If you have G1 or normal or high CKD by GFR, and you have a severely increased urine albumin excretion here, you are already at high risk for progression of your chronic kidney disease. Okay, so let me just orient you with this, with the colors. Green one represents low risk, and the yellow means moderate risk. The orange bars represents the high risk, and the red bars is very high risk. So very important again is that you get your urine albumin excretion with your estimated GFR. You all know this, that the leading cause of end-stage kidney disease requiring renal replacement therapy is diabetes. This is global data, and it includes all similar to that of Philippine statistics. Next will be hypertension. And this is a 20-year study, and if you take a look at this, there has been strides, definite improvement in terms of reducing myocardial infarction and stroke for the past 20 years. But if you take a look at end-stage kidney disease, it remains rather flat. So meaning we really have not made such significant dent into the improvement of incidence of your end-stage renal disease. Now, having said that, let me just give you the scope of the clinical practice guidelines. It includes all kinds of diabetes, type 1 and type 2, all stages of chronic kidney disease, and the interventions that will be discussed includes lifestyle, pharmacotherapy, and systems to improve the diagnosis and treatment of your chronic kidney disease, diabetics with chronic kidney disease. It will not include blood pressure, lipids, and other prevention and screening because they are taken in another set of guidelines. Now, interestingly, new in these guidelines are the practice points. So what are practice points? So there are points in which there is insufficient evidence and the evidence is inconclusive, but the alternative option is illogical. Guidance is discretionary for the physician. And as far as this lecture is concerned, most of the practice points, I will discuss it through a table, a figure, or algorithm, and some of them by text. Okay. Recommendations, on the other hand, is different. They have undergone systematic review, and there is ample and significant evidence, and evidence shows a clear preference for one action over the alternative. And guidance is always actionable. So let's now go to the guidelines. So start with comprehensive care in patients with diabetes and CKD, which includes comprehensive care RAS blockade, and smoking cessation. So this is a pyramid which shows you the different interventions that we should do with our patient. It's a comprehensive care. Like all patients should have good glycemic, blood pressure, and lipid control, accompanied by exercise, good nutrition, and smoking cessation, even secondhand smoke. Most patients will require an SGLT2 inhibitor or blockade of your RAS system. And if your patient has definite cardiovascular disease or has many risk factors to have cardiovascular disease, then antiplatelet therapy is required. Now, this one looks at intensive therapy of the different risk factors, such as your blood pressure, lipids, and your glucose. And it shows us that intensive therapy in trying to correct these different factors does indeed reduce the endpoints from cardiovascular causes, such as non-fatal myocardial infarction, bypass, stroke, amputation, and PCI. So very important is that a multi-pronged intervention to improve cardiovascular disease in patients with CKD. Okay. Recommendation number one is that if your patient has diabetes, has hypertension, and albuminuria, then your patient must be given RAS inhibitors in the form of ACE inhibitors or angiotensin receptor blocker in doses that are highest that will be tolerated by your patient. Now, this is the classical, the landmark trial of Dr. Edward Lewis in 1992, where he used captopril, an ACE inhibitor, and it was said that do not use your ACE inhibitors in patients with kidney disease. And Dr. Edward Lewis did just the opposite. And lo and behold, we now have a slew of landmark of trials using your RAS inhibitors in patients with kidney disease. And this shows, this study showed that the use of captopril was able to reduce the progression to dialysis, transplant, and indeed even death. And a decade later, we have two trials, the IDNT using the ARB, irbesartan, and renal study using losartan, another ARB. And a similar protocol, they were able to reduce the time to primary composite renal endpoints. The other thing to consider is, of course, albuminuria. Now, albuminuria is not only a diagnostic marker, but also an etiologic factor for progression of chronic kidney disease. Once your albumin gets reabsorbed in your tubules, it produces an inflammatory process and thus making a CKD progress. And there are two trials, the IRMA using irbesartan and innovation study using telmisartan proved that ARB was able to reduce urine albumin excretion. So here also we come now to some practice points, and it is said that even in patients with normal blood pressure but with albuminuria, RAS inhibitors may be considered. Okay. You take a look that if you start your ACE inhibitors, your blood pressure goes down. And on the other panel is your GFR. You also have a decline of your GFR with the decline of blood pressure. So the reasons behind this are twofold. One is that you have the reduction of your systemic blood pressure, and you have dilatation of your efferent arterioles of your glomerulus, okay, which is actually the exit doors of your glomerulus. Thus, you're able to release some of the pressure in your glomerulus, decreasing, and both of these conditions will decrease your intraglomerular pressure. Okay. Clinically, what does it mean? It means that your drug is working, and even post hoc analysis by that of the renal study after long-term study they removed the losartan, and it showed that these patients' GFR went back to the direction of baseline. So telling us that the decline of GFR is not structural, it is a functional thing. And it tells us that it protects the kidney. So it's a good thing. Now, the question now is how low is good and when does it become bad? Okay. So whenever we use RAS inhibitors, there are two things that comes to our mind. One is an increase in serum creatinine, and the other one is hyperkalemia. We initiate our patients with RAS inhibitors, and preferably you use the low dose because you don't want to experience the adverse effects immediately with the high dose. Okay. So you monitor serum creatinine and potassium within 2 to 4 weeks when you start or when you change the dosage of your RAS inhibitors. So if you have normokalemia and less than 30% increase in serum creatinine, you can gradually increase your RAS inhibitors to maximally tolerated dose. If you have hyperkalemia, then review the different conditions which can produce hyperkalemia. So you can give moderate potassium intake and consider using your diuretics, specifically your loop diuretics, to reduce your potassium, your sodium bicarbonate, and your potassium binders. If you have greater than 30% increase in serum creatinine, that is bad. And review for causes of acute kidney injury and such as volume depletion and the use of concomitant medications such as diuretics and NSAIDs, and of course, renal artery stenosis. If everything fails, then you have to reduce or stop the dose or stop your RAS inhibitors. Now, these are three sets of population. So set one, population A, started with normal GFR, but they have conditions such as heart failure, volume depletion, or bilateral renal artery stenosis. So you have to rule them out. As you see, there is a steep increase in your serum creatinine. Population B is those patients with chronic kidney disease, and you see there's an initial increase in your serum creatinine, but almost a flat line. Population C are patients without chronic kidney disease if you give them your RAS inhibitor. So you have to take into consideration the factors which will increase your serum creatinine. Now, how about potassium? Okay, so as you see here, an elevated serum creatinine, the use of long-acting ACE inhibitors, heart failure, can increase the incidence of hyperkalemia. And if you use your concomitant use of diuretics, which are potassium losing, such as your loop diuretics, then you may have less risk for hyperkalemia. Okay, but more importantly is that drugs that we give our patient cause hyperkalemia. And let me tell you the mechanism first. At the principal cell of the collecting duct, okay, sodium and potassium are both gut ions. From the urinary space, sodium goes inside and potassium goes outside. So we lose potassium. Now, if we alter that mechanism, then we run the risk of just producing hyperkalemia. So how do we alter that? Well, there's one specific mechanism is to block that sodium channel blockers, as we see in potassium-sparing diuretics such as amiloride, triamterene, or the use of trimethoprim as a combination with sulfamethoxazole and your pentamidine. But the rest of the drugs basically is when you have impaired aldosterone mechanism, and that is caused by your renin angiotensin inhibitors. So they block the the function of your aldosterone. You have aldosterone receptor blockers such as spironolactone, those that impair aldosterone mechanisms such as adrenal disease, heparin, ketoconazole, and those with impair the release of renin, like direct renin inhibitors, your NSAIDs, your beta blockers, your immunosuppressants used in transplant, cyclosporin and tacrolimus, diabetes, and the elderly. Okay. Hyperkalemia associated with the use of an ACE or ARB can often be managed by measures to reduce serum potassium rather than decreasing the dose of ACE inhibitors or your ARB. Now, why should we keep on giving our patients your RAS inhibitor? Why should we make a serious attempt in reducing the serum potassium rather than removing them or reducing the dose? So these are three sets of population, of CKD population. One is those who did not take the RAS inhibitors. Number two, those who stopped the RAS inhibitors and thus were able to take only less than 50% of the prescribed RAS inhibitors. And third is those who took them with more than 50% intake. And what you see here is in terms of mortality, those who did not take and those who took less of your RAS inhibitor died more compared to those who better survival with those who took more than 50% of their RAS inhibitor. This tells us how important the RAS inhibitors, not only for nephroprotection, but also for better survival, such that you can give your diuretics, you can give your loop diuretics, and there are several data in which you use your potassium binders. The data mostly using patiromer and zirconium. Unfortunately, these two drugs are not available here in the Philippines, but I hope they will be coming soon. What we have is Kayexalate, though people say that Kayexalate pales in comparison with the two drugs that I have mentioned. And this is the reason why we need to attempt to seriously reduce our potassium and keep our RAS inhibitors. Okay, so when do you really discontinue or reduce the dose of your RAS inhibitor? So when you have symptomatic hypotension or uncontrolled hyperkalemia. Okay. Also, you do not combine your ACE, your ARB, or even your DRI, or direct renin inhibitor, because they have been found to produce acute kidney injury as well as hyperkalemia. The combination was in vogue a few years back. I myself use it, but it has been identified that it can produce adverse events. Okay, very often in patients with CKD, you have refractory hypertension. And one of the useful drugs that we can use to manage refractory hypertension is the mineralocorticoid receptor antagonist. However, their use is accompanied by hyperkalemia and acute kidney injury. So you have to be careful. You have to monitor your patient as they may have these adverse effects. Let's go for glycemic monitoring and targets. Okay. Okay, this first recommendation is that we should use glycosyl HbA1c to monitor glycemic control in patients with diabetes and CKD. Okay. This recommendation puts priority on availability, cost, and HbA1c being the backbone of most of the trials for CKD management, glucose control, and CKD management. However, it puts less priority on accuracy and precision of glycosyl HbA1c, especially in the latter part of your CKD. So what is HbA1c? You have blood glucose and combining with your hemoglobin. And bias is high if you have metabolic acidosis in CKD. Bias is low when there is anemia, transfusions, the use of your erythropoiesis stimulating agents or your ESAs, iron supplementation. And this one shows you that in terms of mean blood glucose, the other two metrics are glycated albumin, fructosamine. They seem to follow the mean, approximate the mean blood glucose. Okay. Now, if you take a look at this side of the screen, you will see how they fare in patients with chronic kidney disease. And you see that there is less scatter with the glycosylated with hemoglobin A1C. And there seems to be more scatter with the glycated albumin and fructosamine. And one of the reasons that are being blamed for that is that they depend on albumin. And most of our patients with CKD have low albumin at the latter part of their CKD. Okay, so a glucose management indicator derived from continuous glucose monitoring data can use to index glycemia when it appears that your glycosylated hemoglobin or your sugar is not concordant with the clinical symptoms. Okay. The other thing that you can use is self-monitoring of blood glucose may help to prevent hypoglycemia and improve glycemic control. For patients with type 2 diabetes and CKD who choose not to do daily glycemic monitoring or your SMBG, then you should use anti-hyperglycemic drugs that pose a lower risk of hypoglycemia and should be administered in doses that are appropriate for the level of eGFR. Okay. There are several continuous glucose monitoring devices that are evolving. And these are some of it that I will show you. So you have a retrospective, a real-time CGM, and an intermittently scanned CGM. Now, how often should you measure your glycosylated hemoglobin? Okay, so it's usually twice per year for all CKD patients, but maybe increased to 4 times per year if not achieving target or change in therapy. The difference, though, is in terms of reliability. So low, it becomes lower in the latter part of your CKD. Okay, so a glucose monitoring index occasionally useful for CKD1 to 3B and likely useful in the latter part of your CKD. Now, what should be your target? Okay, the target is set as 6.5 to less than 8 and not treated with dialysis. Okay, the higher target level is usually given for those with more severe CKD, macrovascular complications with more comorbidities, life expectancy, impaired hypoglycemia awareness, scarce resources for hypoglycemia management, high propensity of treatment to cause hypoglycemia. The reason behind that is that in the frail patient or the very sick patients, once they develop your hypoglycemia, they do have very serious events, which include increased mortality. So that's the reason here. We want to prevent hypoglycemia as well as the adverse events of the drugs being given. This one shows us that in terms of hazard risk for mortality, if you have patients here using metformin and sulfonylurea, the the lower HbA1c and the higher HbA1c produces more mortality, and it is also seen in patients given insulin. Now, how about lifestyle intervention? Okay. So I really pity the CKD patients. So they're really very, one is they are given dietary restriction, okay? And they're really not very nice. The diet is really not a very good diet to take into. Aside from that, they have to have a decreased intake. They have poor appetite. They're sick, um, and they cannot take enough food because of several comorbidities, acidosis, endocrine disorders, or accumulation of toxins. That's the reason why malnutrition is quite common in patients with CKD. Okay. Recommendation number one is that the protein intake of 0.8 gram per kilogram for those patients not on dialysis. Okay. The reason behind that is that the protein that we take are the sources of our uremic toxins, and the more protein that you take, they produce more toxins. Similarly, the protein load increases, produces an increase in your intraglomerular pressure, and your single nephron GFR increases. However, if you continually do that, even though your single nephron GFR increases, eventually you will have tiring out of your nephron, and your nephron eventually dies. Okay. Now, with patients undergoing dialysis, we are not anymore, sad to say, protecting some kidney function, unless unless of course their residual GFR is about 10 mLs per minute, and because we lose protein in our renal replacement therapy, especially in peritoneal dialysis, we can increase our protein intake to 1 and 1.2 gram per kilo. Now, what should be the diet? It should be high in vegetables, fruits, whole grain, fiber, legumes, plant-based proteins, unsaturated fats, nuts, and lower in processed meat, refined carbohydrates, and sweetened beverage. And this is a drawing which you can show your patients. So the usual plate, the rice ball, the pita bread, and the banana leaf. So taking more, prioritizing plant-based diet. Why a plant-based diet? So if you take a look at this comparison, you see that there are more protein compared in animal meat, in animal food, compared to plant-based proteins. And if you take more plants, then you will also take less protein. And I guess this is quite known to you. We suggest that sodium intake be less than 2 grams of sodium, or less than 5 grams of sodium chloride per day. Okay, because decreased sodium intake decreases blood pressure, and it produces a decrease in cardiovascular disease, risk of stroke, and progression of your chronic kidney disease. So how are we going to achieve that? So there are several ways to cut out salt, but let me just point out a few things which I emphasize my patients. Rather than go out in fast foods, buy fresh foods and cook at home. Read the labels. Sometimes lower salt brands can contain potassium, and they can increase the damage here. They can produce hyperkalemia. And avoid salty processed meat. Use fresh meat and poultry. Okay. And I always tell my patients, on the table, do not use any more salty sauces like soy sauce. Nutrition is really a difficult thing for patients with CKD, and yet it is the cornerstone of therapy, and it's very important. So we must have a shared decision making, which should be the cornerstone of patient-centered nutrition management with with patients with CKD. And it might be difficult, really. And as a matter of fact, I would say when people start asking about their nutrition, they're very, very conscious. They're very, very anxious about their nutrition, and some for very anxious with their nutrition. Some would like to take some more. Some are afraid to take more, and so there are two sets of population here. One who feels that they're being deprived, and one who's very anxious that they will take the wrong kind of food. And having said that, it really takes up so much of your time, and you should have a wide knowledge on the different food materials that your patient will be asking. And for better care, you can ask the help of an accredited nutrition providers, registered dietitians, diabetes educators, even peer counselors to help you out in planning the diet of this patient. Lastly, you should take into consideration cultural differences, food intolerances, variation in food resources, cooking skills, comorbidities, and cost. Right now, vegetables are rather costly because of the monsoon rains. Okay. How about activity? In terms of activity, it is advised that your patient should undergo moderate intensity physical activity for about 150 minutes per week, or to a level compatible with their cardiovascular and physical tolerance. So these are the different intensity from sedentary to vigorous. And well, most of our patients will be probably in sedentary and light. Okay, this is the meta-analysis and systematic review of CKD 225, dialysis therapy or kidney transplant. With intervention is regular exercise training. And their conclusion is that regular exercise training generally is associated with improved health outcomes in individuals. Correctly designed exercise rehabilitation may be an effective part of care of adults with CKD. This is the physical activity intensity levels in patients with CKD. This is US. And if you take a look, there more than 50% will have sedentary and low activity. And probably the reason behind that is they are sick, they are frail, they do not feel well, and that's the reason why they have this low level of activity. So we have our hands full in probably increasing their level of activity. So how do we do that? So first, you should assess baseline physical activity level. If they're sedentary, assess for fall risk. So you have to devise an exercise in which it is safe for them. Comorbidity burden should also be considered. Okay, so you start with low intensity activity and increase activity as tolerated. If it's high risk, you better refer to a physiatrist or rehabilitation or to an exercise specialist. If your patient is physically active for less than 150 minutes a week, then recommend to increase the physical activity to more than 150. And if they're doing more than 150 a week, and your recommendation is now muscle strengthening activities. Next is we will take up anti-hyperglycemic management in our subset of patients. And recommendation is that we recommend treating patients with metformin if their eGFR is about greater than 30 mils per minute. And this can also be given to kidney transplant recipients. Next recommendation is prioritizing the use of SGLT2 inhibitors if their eGFR is greater than 30 ml per minute. Okay, this is the algorithm. You have lifestyle therapy. The first line therapy is metformin, reduce dose for less than 45 mils per minute, discontinue if they're less than 30 and when they start their dialysis. And I guess the reason behind this is the fear of lactic acidosis, though recent data have shown that the occurrence of lactic acidosis, metformin is not a monocomponent. Usually metformin can be a factor in lactic acidosis if they're accompanied by other conditions such as dehydration, sepsis, heart failure, or even an infection. Then the other first line therapy is your SGLT2 inhibitor. Do not initiate with less than 30 mils per minute and discontinue with dialysis. If your patient is not tolerant to any of the two drugs, or they prefer something else, or if their GFR is less than 30 mils per minute, then you have your GLP-1 receptor agonist, your DPP-4, insulin, and even your sulfonylurea. Now, how do we use your metformin? Okay, so if your GFR is less than 30, then you stop your metformin. If it is, if they are more than 30, up to 60, 45 to 60 mils per minute, then you can give your immediate release and extended release at your usual dose. Start with a low dose, then titrate upwards until you reach maximum levels. If your GFR is 30 to 44, initiate at half the dose and titrate upwards to half of the maximum recommended dose. If they have been taking it for more than 4 years, then you give your vitamin B12. Okay, for patients with 45 mils to 60, more than 60 mils per minute, for greater than 45 mils per minute of eGFR, you check your kidney function annually. And for those with 45 to 45, 30 to 45 rather, I correct that. So if your patient has greater than 60 up to greater than 60, then you can monitor your kidney function annually. If your patient is 45 to 30, 45 to 30, then at least 3 to 6 months. Okay. Now the subsequent dose adjustments will depend on the GFR that you check on your that you monitor. Now this one shows to us the how we should give priority to our SGLT2 inhibitors. Okay, if you have not reached your glycemic target, then SGLT2 inhibitors should be added. If you have reached your glycemic target, but you can safely achieve a lower target, then you can give your SGLT2 inhibitor, add that. But if you cannot achieve, if it is not safe for you to achieve a lower dose, a lower target, then very important is that you reduce the dose or discontinue some of your anti-hyperglycemic agents, except that of metformin. It is reasonable to withhold SGLT2 inhibitors during times of prolonged fasting, surgery, or critical medical illness. So when patient may be at greater risk of ketosis. If patient is at risk for hypovolemia, consider decreasing your diuretics before commencement of your SGLT2 inhibitor, and advise patient about how to recognize volume depletion be able to measure blood pressure and prevent occurrence of low blood pressure. Patient preferences, comorbidities, GFR, and cost should guide selection of additional drugs when needed, with glucagon-like GLP-1 receptor agonists generally preferred. And this is the factors influencing selection of glucose-lowering drugs. So these are divided into more suitable and less suitable depending on the presence of heart failure, high risk, atherosclerotic cardiovascular disease, potent glucose lowering, avoiding hypoglycemia, avoiding injections, weight loss, low cost, or a GFR of less than 50 mils per minute. So these are the different drugs which you can use. Now, this one is just showing you a meta-analysis. I'm quite sure you're all familiar with this, that the use of SGLT2 inhibitors can retard, delay the progression of your CKD. Not only that, it also has benefits on major cardiovascular events. This has been quite talked about. Now, a few words on why the SGLT2 inhibitors can produce nephroprotection. So here, if you have the diabetic nephron, in the diabetic nephron, there is reduced feedback from the macula densa because less sodium and glucose is transmitted to the macula densa. And what it does is there is afferent vasodilatation. If there is afferent vasodilatation, you open the doors of your glomerulus, thus exposing the glomerulus to the systemic pressure, producing intraglomerular increase of pressure. On the other hand, there is increased feedback from macula densa when you start giving your SGLT2 inhibitors because you have more sodium and glucose being appreciated by the macula densa. And what it does is that reversal of your afferent vasodilatation. So you tighten the entrance to your glomerulus, and when you tighten that, you reduce the intraglomerular pressure. And that is also the reason why you have an initial decline of your eGFR when you give your patient your SGLT2 inhibitor. And as I have mentioned earlier, the same thing with RAS inhibitor, once you reduce the intraglomerular pressure, it is nephroprotective. As a reversible decrease in eGFR, I have been mentioned and as I have explained, is generally not an indication to discontinue therapy. Okay, it is reasonable to continue SGLT2 inhibitors if eGFR falls below 30 mils per minute if you have initiated and started your SGLT2 inhibitors, unless it is not tolerated or kidney replacement therapy is initiated. Okay. A very commonly asked question is, can we give it in transplant patients? There are several studies, small ones at that they say that there is no drug-to-drug interaction with your SGLT2 inhibitors, but there is only a small risk of giving of infection. However, SGLT2 inhibitors in all of these studies were given at the point where they were already given maintenance low doses of your immunosuppressant. However, because of that risk, because these patients are immunosuppressed and there are no adequate studies, as I mentioned, all the studies were small and short. Because of the increased risk for infection, the recommendation to use SGLT2 inhibitor does not apply to kidney transplant recipients. So another recommendation is that those who have not achieved glycemic target despite use of the metformin and SGLT2 inhibitors, or who are unable to use those medications, we recommend the use of long-acting GLP-1 receptor agonists. And these are the meta-analysis, and it shows that your GLP-1 receptor agonist has improvement in terms of major cardiovascular event. And practice points, the choice should be prioritizing agents with documented cardiovascular benefits, minimize gastrointestinal side effects. So you start with a low dose, especially with your CKD patients, and do not combine it with DPP-4 inhibitors. Okay. And as we all know, the risk of hypoglycemia is low with GLP-1 receptor agonists. So these are the dosing for GLP-1 receptor agonists. Many of them has no dose adjustment, okay, but there is limited data for severe CKD. Okay, so you should take that into consideration when you give your GLP-1 receptor antagonist. And these are the cardiovascular mortality and kidney outcomes with GLP-1. So it reduces cardiovascular mortality, hospital admission for heart failure, and composite of your kidney outcomes. So these are the different studies done on your GLP-1 agonists. This is from the KDIGO. Of course, we know already that the DAPA-CKD and the Fidelio-DKD studies have been completed. We're still awaiting the EMPA-Kidney. And this is the Fidelio study using finerenone in chronic kidney disease outcomes in type 2 diabetes. And their conclusion is that in patients with CKD and type 2 diabetes, treatment with the non-steroidal finerenone resulted in lower risk of CKD progression and cardiovascular events than placebo. Okay, there is a second part, which is the Figaro trial, using almost the same patient but with higher risk, cardiovascular risk. This is a cardiovascular outcome trial with secondary kidney outcome, and the collection has been done, and we were awaiting. Collection has been finished. Data collection has been finished, and hopefully we see the results in print very soon. The other one is your DAPA-CKD. Probably this has been discussed to you so many times. This takes into consideration renal endpoints in patients with and without type 2 diabetes, and the intervention is dapagliflozin 10 milligrams. And let me just show you the results. And DAPA-CKD will determine whether the SGLT2 inhibitor dapagliflozin added to guideline recommended therapies safely reduce the rate of renal and cardiovascular events in patients across multiple CKD stages with and without diabetes. The last is the approaches to management of patients with diabetes and CKD. It is recommended that a structured self-management educational program be implemented for care of people with diabetes and CKD, which the following objectives: improve diabetes-related knowledge, belief, and skills, self-management and self-motivation, adoption and maintenance of healthy lifestyle, improve vascular risk factors, increase engagement with medication, glucose monitoring, and complication screening programs, reduce risk to prevent or better management of diabetes-related complications, and improve emotional and mental well-being, treatment satisfaction, and quality of life. And for policymakers and institutional decision makers, should implement team-based approach and team-based integrated care focused on risk evaluation, patient empowerment, and to provide comprehensive care. So I do hope we are able to accomplish this, and this organization can spearhead that um, program for that. Okay, and I've been talking for maybe 40 minutes or so, but you just take a look at this diagram, and this probably is the summary of what I have just discussed. And the goals of our treatment is to treat to multiple target levels, use of organ protected drugs, and ongoing support to promote self-care. So its objective is to empower patients with optimal control. Okay, and this is another central illustration, which also summarizes the talk. This is the overall summary. First is the KDIGO guidelines on diabetes, and CKD is now available. Provide recommendation and practice points on comprehensive care, glycemic monitoring and targets, lifestyle intervention, anti-hyperglycemic therapies, and approaches to management of patients. There is patient-centered decision-making and support, and consistent efforts at improving diet and exercise remain the foundation of all glycemic management. The control risk factors, including RAS blockade, remains part of the standard of care. Glycemia is monitored with HbA1c and blood glucose. Glycemic targets should be individualized with focus on increased risk of hypoglycemia with declining kidney function, and initial use of both metformin and SGLT2 inhibitors is recommended, and healthcare organization should support a coordinated effort. This is the last of my slides, and I would like to thank again the organizers for the pleasure to be with you, and also for your kind attention. And I will be available for any of your queries. Thank you very much.
Thank you very much, sir. Indeed, it was very extensive but practical. So yung mga pointers na binigay na also coming from the KD ko, yung practice points at saka yung recommendation in treating our patients with diabetes and CKD are very practical. So I hope that you can apply this to our patients. So I'm now opening the floor for any questions for our speaker. Kung may tanong din po kayo kay Dr. De Los Santos, nandito rin po siya. So just a quick comment, sir, from Dr. Ray Rosales. So great lectures. So may questions din po siya. So what is the most accurate formula to estimate your GFR? So is it the CKD-EPI, the MDRD equation, or the Cockcroft-Gault formula? Siguro nag-aaral pa ako, Cockcroft lagi yung ginagamit.
Before when we were first using the formula, it was usually Cockcroft-Gault. And as a matter of fact,
yes,
still its importance because most of the pharmacokinetics of the drugs, the estimated GFR formula being used are usually the Cockcroft-Gault. So you have to take that into consideration when you take on in terms of dose reduction in patients with CKD. But answering the question of Ray, the KDIGO recommends CKD-EPI. There is also a study done in the Philippines by Dr. Sebastian already, and he compared the different formulas, and it is also in accordance with the KDIGO recommendation that CKD-EPI is more appropriate for the Filipinos. But of course, the creatinine that you should be using should be similar to that of the National Kidney Institute where the study was done. The Philippine Society of Nephrology has been arguing with pathology in the hope that they standardize their serum creatinine. As you see, different laboratories have different values for your serum creatinine, different normal values, and sometimes it's really difficult when you compute for your estimated GFR to explain to your patient it's normal but your kidneys are bad. So we do hope that we have a standardization of your GFR formulas. The um, the 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 CKD epi does not take into consideration your muscle mass. But if you have the extremes of muscle mass, then you might have to use the MDRD trial. So the markedly obese and that of the anorexic or emaciated patient.
Thank you, sir. I see those patients talaga coming from another laboratory, then they presenting to you results nila.
Yes.
Tapos, pagpaulit mo naman, biglang maging normal na. Tapos,
Yes. As a matter of fact, I always recommend my patient that if you're going to the laboratory, when we follow you up, use the same laboratory. But if they say the expensive, I will always urge them, use the same laboratory for the first few times, but later on we can probably go for a cheaper one. But I agree with you. You have to ask your patient to use the same laboratory.
thank you, sir. There are more questions coming in the chat box. Pero unahan ko lang muna sila, sir. Kasi we see this mostly in our patients, especially mga diabetics with other comorbidities. Pag dumadating sila, makikita na pag tumaas yung creatinine nila, ang CCC nila kasi ang dami daw nilang gamot na iniinom, kaya nasisira ang kidneys. So how do you handle this, sir? Yung mga ganitong queries nila sa dami ng gamot.
Kasi that well, I always tell them it's good you have medicines to take care to take rather than you have diseases where no medicines can be taken. So we're always have a tug of war with different specialties because as a nephrologist, it is our job to see if the dose being given is appropriate. So when the patient comes to me like that, and I guess we're different specialties. So when a patient comes to me with a list of drugs, I tell them, give me some time. I will do some computations and to see if the dosages are okay. So while it is true that a polypharmacy can do something bad to your patient, but you have to convince them that they are necessary. And I guess proper dosaging should be important.
Thank you, Doc. Sometimes kasi pagka a lot of drugs na, sila mismo yung nagbabawas. Kaya pag dumadating sila, lalong nasisira yung kidneys nila because of they are not using their drugs properly. Another question. Yes, sir. Go ahead.
We have changed the dose. Adequate naman yung dosage. Appropriate yung dosage. I think that's one way that we can give confidence to our patients.
Thank you, sir. Another comment from Dr. Arima Tanpo, sir. So, ang galing best teacher daw po. So, may questions siya. Also coming from the other participants on the role of your keto analogs and sodium bicarbonate in patients with CKD.
Okay, good. Let's start with keto analogs. Recently, the Kidney Disease Outcome Quality Initiative has just presented guidelines on diet. Okay, so they divided CKD on two populations, one with diabetes and one without diabetes. So yung keto analogs was prescribed for those patients without diabetes. So when you prescribe keto analogs, dapat may formula, no? Ang formula rito is a supplemented very low protein diet, 0.15 to 0.3 grams of protein per kilogram. So very low, and you supplement then with keto analogs. And the keto analogs is about one tablet per 5 kilograms. So unfortunately, keto analogs are given a bad rap kasi underdose, 1 tablet 3 times a day, 1 tablet once a day, when in fact you could be giving 9 to 12 tablets a day and a very low protein diet. So the other population ng KDOQI is that 0.8 with the keto analog. So this has been and a vegetarian diet because of the Garniata trial. However, hindi nila piniprescribe ang keto analogs with that of diabetic patients, because there are really very little studies on diabetic patients, because in diabetic patients you already lose uh, so much. There is increased proteinuria, and that's the reason why baka kung you will put them on a very low protein diet, magkakaroon sila ng protein malnutrition. So the keto analogs, as far as the KDOKI, was reserved only for CKD without diabetes.
Sir, how about yung sodium bicarbonate?
Oh, okay, sodium bicarbonate. Okay, very good question. I appreciate that question because very important. Don't just give your sodium bicarbonate without getting your blood gas. That's very important. And the reason why sodium bicarbonate is being given is that if you maintain your sodium bicarbonate in normal levels, it has been shown that it retards the progression of your chronic kidney disease. So kung meron ka talagang acidosis, mas mabilis ang progression ng chronic kidney disease. So sodium bicarbonate is important.
Paano yun, sir? May ano po ba yan? Level lang kung paano bibigay? Kasi
20
some I see 325 lang, yung iba 650 agad.
As I said, you have to have a baseline measurement and probably recheck it. So basta ang recommendation is about 20 to 24 max.
Okay, sir. Thanks. Pero how frequent will you measure yung blood gas, sir? Isang baseline tapos after.
If you have stabilized your patient, then it's okay. Unless, of course, there are sick days when your patient gets hospitalized, they get some infection, then you can recheck your blood gas.
Thank you, sir. May madami pang questions, sir. In patients with moderate kidney disease, sabi po nila yung nephrologists usually discontinue the phenol-5-3. So, any reason for that?
Okay. Okay. The recommendation for lipids kasi is that it is best to use your statins, hoping that your statins will also, we know very well statins not very good for your triglycerides, hoping that enough statins will reduce your triglycerides. Of course, when you're at the very high levels of your triglycerides, you can use your fenofibrates. I often combine them at high levels if I'm not able to reduce my triglyceride with just the use of statins and diet. Then I give my fenofibrate. However, I always tell my patient to watch out for muscle pains, and I ask them to come back for a liver function test. So I guess the guidelines tells us by the KDIGO in lipid management, use statins first.
Okay, thank you, sir. We are seeing patients also with very high triglycerides, especially if they concomitant problem is yung may mga fatty liver din sila.
I don't think the CKD will be a reason for you not to use it, but you should be careful on the side effects because the side effects will be more.
Okay, sir. Thank you po. Another one about the SGLT2, sir. So after resolution of the acute kidney injury or failure, when is the safest time to resume your SGLT2 inhibitor?
Okay, so when you have resolved your acute kidney injury and the triggering factor which caused the acute kidney injury is not present anymore, so the statement is resolved. So wala na. I think you can start already your SGLT2 inhibitors.
Okay, sir. Ito pa, sir. Meron din yung another question on SGLT2 inhibitors because it has a significant effect or benefit on the heart and kidneys among patients with COVID-19 infection. So, pwede ba daw po i-continue pa yung can SGLT2 inhibitors attenuate the COVID-19 progression in high-risk patients with diabetes?
Yes, there are some data which says that SGLT2 inhibitors can help in terms of kidney disease and cardiac disease in patients with COVID. But if your patient has COVID, um, I can ask the group, will you still give your SGLT2 inhibitor? You probably will shift it to insulin
Yeah,
or
insulin, yes.
insulin. So
Yes, sir.
probably not wise to use the SGLT2 inhibitors.
Yes, sir. I agree po. Talagang insulin po yung pag mga, especially mga severe or critical patients with COVID. May question pa rin po, sir, about other medicines. Like yung those medicines that nasasabi na may benefit sa endothelial dysfunction to prevent deterioration of your kidneys in diabetic patients.
Such as?
Siguro po yung mga alpha lipoic acid o kaya mga sulodexide.
I think if you take a look of the different for a diabetic nephropathy, mukhang very weak ang alpha lipoic acid as well as your sulodexide in terms of diabetic. The evidence has been rather weak, and I don't see any recommendations or guidelines giving alpha lipoic acid as well as sulodexide.
Okay, sir. So, sabi nga po dito, sir, i-confirm lang daw po the keto analog use. It should not be used in CKD caused by diabetes kidney disease.
And I just mentioned the guidelines that the recommendation is it is not recommended for patients with CKD with diabetes. However, there is a similar study, the one that the Garniata trial again use the keto analogs to delay the progression of your chronic kidney disease. However, what she did was that instead of using a very low protein diet, he used a low protein diet, knowing very well that these patients have a increased albumin because of urine albumin excretion. Personally, I do use my keto analogs, taking into consideration that very well I have to see very well whether malnutrition does occur with patients using keto analogs. Because as I mentioned earlier, the formula is low protein and the appropriate dose of keto analogs. So keto analogs are not for everybody. So as far as the guidelines says, hindi pa siya recommended, but I do use it.
Yes. And also, sir, sabi nga, may isang nephrologist, when you are going to use it, you give it 2 tablets 3 times a day kasi yung 1 tablet 3 times a day daw wala naman din
magiging 2 tablets 3 times a day, these are data from Asia kung pwedeng 2 tablets 3 times a day. But the actual dose is 1 tablet per 5 kilo. So kung ikaw ay 60 kilo, you need 12 tablets. Kaya nga ang formula kasi is your patient is motivated to take a very low protein diet plus the appropriate amount of your keto analog. Kaya nga sinasabi ko, minsan bad rap ang keto analogs kasi dami ko na ito, hindi naman gumagaling. The reason behind that is hindi naman nag-low protein diet.
Yes.
Hindi naman tama yung dosage ng keto analog. So as I said, the formula twofold. Kaya kailangan to be successful. Saka nga yung Garniata trial, it's usually a vegetarian diet.
May isa pa, sir, na nakikita na din natin yung ginagamit. Yung any comments po on the use of your cremazine in CKD patient?
Cremazine or AST-120 is an absorbent. So what it does is yung phenylcresol, cresyl sulfate. So they are said to be uremic toxins. Once they get absorbed once they are formed as a protein metabolism in the gut and gets absorbed, they produce a further progression of your chronic kidney disease. So yun ang kanyang mechanism of action. Okay. Now, if I do give cremazine, kasi if I say keto analog, you have to take this low protein diet, and some will say I cannot do that. So you this is one cremosine is one thing that I can suggest to you. However, whenever I give my cremosine, I always tell them, if you look at Google, it will tell you it does not work, because the biggest trial done in the United States says it did not work. It did work only in those patients with hematuria and those with rapidly rising serum creatinine. However, if you take a look at Asian studies, Korean, Japanese, and Taiwanese trials, they are very beneficial. As a matter of fact, the manufacturers of cremosine were telling us that there is a heterogeneity of the chronic kidney disease, different than Asians compared to that of the Caucasian. So when I give that, I always tell them this, because if they see it, they Google it. Alam mo, marami ng Dr. Google, di ba? Marami ng
Yes,
Dr.
sir.
Google. Google nila, it doesn't work. Magagalit sa'yo kasi mahal naman yung masyado yung
Yeah.
medicine. But I do have experience, and it causes really a retardation of the kidney disease if given properly.
I agree, sir. Kasi the pathology sa Asian at saka sa non-Asians in having diabetes is also different. So, magkaiba din po yung mga, kaya siguro iba din yung management in terms for
You
city.
just have to inform them about, if you take a look at the internet, you will see this. Kasi baka later on, mahal-mahal, sinusugod ka. It does not work.
Sir, may follow-up question po. Do renal patients get more hepatic toxicity with phenofibrates than patients with normal renal function?
Yes, they do. They do. They do.
So pagka meron talaga.
Yes, they do.
Yes, sir. With regards naman po sa A1C level, until what level of hemoglobin would A1C still be reliable in measuring the glycemic control? Kasi yung mga CKD natin paiba-iba sa
as I mentioned, so if you have at the latter part, maybe CKD 4 and 5, and when your hemoglobin is already below 8, then it becomes less reliable. So that's the reason why sabi ko nga sa recommendations, it puts priority on availability and cost, not on accuracy. So probably that. Stage 4 and 5, G4 and 5, and hemoglobin of 8 or 9.
Oh, thank you, sir. So pag mga 10, pwede pa tayong A1C.
Yes.
Tama po ba, sir? Okay. So, okay, I think we have answered almost every questions in the chat box. Okay, so isa na lang, sir. Meron kasi akong patient na nephrectomy. So isa na lang yung kidney niya. And then, diabetic siya with a normal kidney function. Would you recommend an SGLT2 to this patient?
As I have mentioned kanina, they do not recommend the use of SGLT2 inhibitors to transplant patients. But as I mentioned, there are small studies in which they have used SGLT2 inhibitors at the time when they have stabilized the dose of their immunosuppressants. Small numbers, small duration, and there is no drug-to-drug interaction, kasi very important in transplant patients is yung drug-to-drug interactions with the immunosuppressants that you have. But the infection rate is not that great. Kaya nga sinasabi nila, the recommendation is there should be more studies, because their initial findings is that the infection rate is not that great, larger than compared to the usual. But the recommendation is wag muna.
Okay, so with that, if there are no more questions, we would like again, sir, thank you very much for your time. Okay, so okay na nga po natin si sir. So sana po next time ulit po pagka
anytime.
Pwede po available po.
I'll be happy.
Thank you. Thank you po, sir. So, Again, we would like to thank all our participants and Dr. Royland De Leon and our two speakers, Dr. Grace De Los Santos and Dr. Balmores, for this month's topic on diabetes and the kidneys. So just a reminder, for next month on September, we're going back to basics and we'll be dealing about biochemistry, okay, and diabetes. So with that, thank you all for your attendance and hope to see you next month, September 4 po. Okay? So paalala din, please register na sa ating ISD convention this coming October. So 500 po until August 31. So you can visit our webpage. Okay? So ISDFI webpage. So attend po kayong lahat and 500 pesos pa rin po yung ating registration. And after that, tataas kasi sa September, magiging 2,000. Okay? So good night everyone and stay safe. Thank you again sa AstraZeneca and sa Gets Pharma for helping us with this webinar. Thank you and good night. Thank you.